Good evening and welcome to Doctors on Call. I'm Dr. Ann Stephen, a pediatrician and chief medical officer in the East with Essentia Health, and I'm your host for our program tonight on lung problems. Our panelists this evening are Dr. Ryan Harden, a faculty member at the medical school in Duluth and family medicine physician at the Gateway Family Health Clinic in Sandstone, Dr. Andrew Keenan, a pulmonary medicine specialist with Essentia Health, and Dr. Jason Wall, a family medicine physician with the Duluth Family Medicine Clinic. Our medical students answering phones tonight are all from Minnesota. Claire Baumgardner of Bemidji, Michaela Lassard of Grand Rapids, and Jennifer Tamala of Big Lake. Please call in your questions on pneumonia, influenza, asthma, COPD, lung cancer, or any other lung problems you have concerns about, and we will do our best to address them. The telephone numbers for those questions can be found at the bottom of your screen. And now, on to tonight's program. I have some questions here that we'll start with, and we have some questions we'll be waiting for from our callers to come in also. Dr. Wall, is there a shot that can help prevent pneumonia in adults?
Thank you, Dr. Stephen. There are two pneumonia vaccines, and the first is called PCV13 or Prevnar 13, and the second is called PPSV23 or the Pneumovax. And classically, when people become around Medicare age, around 65, you're offered the PCV13 at age 65, and then a year later, you get the PPSV23 at a year after that, so around age 66. I guess what I would like to highlight is that anybody with asthma, certain lung problems, COPD, are actually eligible for the PPSV, the Pneumovax, from age 19 to 65. So anybody you know who's potentially a smoker or has asthma should talk to their physician about getting the Pneumovax, the PPSV23.
Oh,
and these can help prevent the morbidity and death associated with a pneumonia.
Thank you. Dr. Keenan, I've been smoking for so long, does it really matter if I quit now is the question, and should I be screened for lung cancer?
Okay, well, I tell my patients it's never too late to quit smoking. Within minutes of quitting smoking, we can start to measure changes in your lung function. Cough often improves over the first few days, and then we see improvement in shortness of breath, and also over months to years, decreased risk of problems associated with smoking, including chronic lung disease and risk for lung cancer. As far as the second question, there's a specific group of people who we screen for lung cancer, people who have smoked for a certain period of time in a combination of packs a day and years smoked, we say about 30 pack years. Mm-hmm. Also people who, and these people who continue to smoke or who have quit smoking less than 15 years ago. So there's a little math to it, but if you are a current smoker or are a former smoker, it's good to talk to your physician about whether you're a candidate.
Mm-hmm. Thank you. Dr. Harden, what is sleep apnea, and how do I know if I have it?
So questions about sleep apnea I get in my practice quite commonly. Sleep apnea is a condition in which individuals who have it will actually stop breathing a number of times while they're sleeping. And that causes a number of things, a number of symptoms. They won't get restful sleep, so the next day they won't feel like they're rested, and they will commonly fall asleep while they're watching TV, while they're sitting at a stoplight in traffic, or when they're out with their significant other watching a movie for Valentine's Day, they might fall asleep. The sleep apnea is usually associated with overweight or obesity, though not always. But the reason that you would want to get treated if somebody had sleep apnea is over the long term, it can cause high blood pressure and changes in heart function.
Okay, thank you very much. All right, so I have another question here. Dr. Wall, should I use my inhaler every day?
Excellent question. My first question would be is what inhaler, and if it's a controller medication for your COPD, which stands for chronic obstructive pulmonary disease, or your asthma, yes, you should use it every day. Conversely, if you have a sort of a rescue inhaler, something like an albuterol, or trade name would be like a Ventolin, if you're using that every day and using it frequently, that can be a sign that you need to have some changes made to your medication regimen, such as long-acting beta agonists, inhaled corticosteroids, other medications that can help prevent you needing to use your rescue medication. So I guess I'm not directly answering your question, but you know, if you're using this inhaler to control your COPD or asthma as a controller medication, absolutely use it every day. If you're using it because it's albuterol and you are feeling short of breath, you're wheezing, or your COPD, you're having a hard time breathing, that's probably a red flag that you need to, you know, perhaps go to the hospital and at a minimum talk to your physician right away.
Thank you. I have a question now from Dale in Carlton. Dale is wondering, what is the difference between idiopathic pulmonary fibrosis and regular pulmonary fibrosis? Dr. Keenan.
That's a good question. So there are a number of different lung diseases that can cause fibrosis, and you can just think of that as scarring in the lung. Just like if you have a cut on in your skin, it forms a scar. Sometimes there can be a type of injury in your lungs that forms a scar. Well, there are a number of different diseases that can cause this. One that gets quite a bit of our attention is idiopathic pulmonary fibrosis, excuse me, or IPF. And this is a disease process. We don't fully understand the inciting cause, but after it's diagnosed, it tends to progress very quickly, cause a lot of symptoms, and leads to either someone's death or need for pretty radical treatment like a lung transplant. The other reason it's become more an area of interest is just in the last 5 to 6 years, 2 new medications have been approved that can slow the progression of IPF. And these are very specific to just that disease. We don't prescribe those yet for other types of pulmonary fibrosis. But I think if you have a chest x-ray or a CT that says fibrosis, or if you're concerned about that, talk to your physician, because the most common processes that cause fibrosis are not idiopathic and often have more benign courses.
Thank you very much. The next question is from Brad in Duluth, and Brad is wondering if there's a connection between COPD and heart disease.
Well, there's definitely a connection between COPD and heart disease. Since the heart pumps blood to the lungs and the lungs receive blood from the heart, there's a direct relation between heart function and lung function. So the heart pumps blood to the lungs to get oxygenated, and then the blood comes back to the heart to get pumped to the rest of the body. So that if there's a problem with lung function and the lungs can't appropriately oxygenate the blood, that will usually over time interfere with normal heart function. So there's definitely a direct relation between heart and lung function.
Thank you very much. Now I have a question from Superior, Dr. Wall. What lung conditions might cause acidic smelling breath?
That's a fascinating question. Usually, I think of diabetic ketoacidosis causes kind of a fruity, acidic smell when people, but I think I'm going to defer to my colleague, Dr. Keenan here, because I cannot think of one. Yeah.
Well, we do hear that concern on occasion in people who have a specific type of lung infection called a lung abscess. It's a fluid collection in the chest that communicates with the airways, and when they cough things up, it can be described as foul tasting or an acid brash. I think that's relatively uncommon, and it might be more often some bad reflux or something like that.
That's kind of what I was wondering too. I have two questions that sort of overlap. I'll move on to you, Dr. Keenan. Debbie from Hermantown is in her 70s. She's a healthy non-smoker. Her primary care doc x-rayed her lung and found a nodule but didn't seem worried. She wants to know if she should be followed up. And a caller from Two Harbors says, what is a lung nodule and should I be worried about having one?
So to the first question, certainly seeing, like I mentioned before, seeing an x-ray report that has something you don't understand can be concerning. The nodule, if it was present in the past, particularly if it looks stable under a at least 2-year period, it's something we'd consider to be likely not something that would cause a problem. If you aren't sure about why your doctor is not concerned about it, it's always fair to ask them to explain it. If they're not sure how to approach a lung spot, then they're always welcome to talk to one of the local pulmonologists to see what they would recommend. And related to the second question, with all the imaging that people get for a variety of issues, we are encountering more lung nodules, some that we were anticipating, some that appear and are unexpected, and a lot of things such as whether it's been present before, the size, the shape, and other risk factors really affect how we think about the lung nodules. So I think if you do have imaging that shows a lung nodule, it's best just to talk to your physician about it and see what type of follow-up they'd recommend.
Great, thank you. William in Hermantown, what is the prognosis for COPD, and is it associated with lung cancer?
That's a great question. So the prognosis for COPD really depends on the severity of COPD. Some people have mild cases, moderate cases, and severe cases, or end-stage COPD. So can you ask me the second part of that question again?
Yes, does it cause lung cancer, or is it associated with lung cancer?
So lung cancer, COPD is predominantly caused by cigarette smoking. Most lung cancers are caused, 90% of all lung cancers are caused by cigarette smoking. So I wouldn't say that COPD leads to lung cancer, but the cause of COPD and the cause of lung cancer are both smoking. So if somebody has COPD, which is probably caused by smoking, that automatically puts them at higher risk for developing lung cancer, but it's not because of the COPD.
I got you. Thank you very much. Dr. Wall, this is from Patty in Duluth. Can I contract pneumonia from using a CPAP machine?
Thanks for that question, Patty. There are certain bacteria that can harbor within the tubing. So keeping the tubing for your CPAP machine, replacing it on a regular basis and keeping it sterilized. The classic would be Pseudomonas, is a bacteria, gram-negative bacteria that likes to grow in warm, moist areas. And there are a lot of other pathologic bacteria that like warm, humid environments that could potentially grow in that. And so certainly replacing it as directed, and I don't know the exact interval for replacement. And then I think there's some recommendations about how you sterilize it, what solutions you can use too. So certainly CPAP hygiene, CPAP patients find it extremely helpful, but there is maintenance. You do have to keep it clean, otherwise you would place yourself at a risk for a potentially very serious bacterial infection.
Are a lot more of your patients on CPAP these days?
Yes.
Yeah.
Yes.
And if I could add,
Yeah.
if you do have pneumonia, if you get pneumonia and you use CPAP, I would not blame it on the CPAP. I think it's probably related to another thing. I think your points are good, but the CPAP is probably helping much more than it's hurting.
This is an interesting question from a caller from International Falls for you, Dr. Keenan. Could the doctor comment on pharmoplasty as a therapy for bronchial disease?
Oh, okay. So I think the term we're talking about is thermoplasty.
Ah. Okay,
And-
it says pharmaplasty. Thermoplasty, okay.
Yeah.
Okay.
So there is a procedure called bronchial thermoplasty, and what this is a treatment for very severe, difficult to control asthma, where going in through into somebody's airway with the bronchoscope, we use a special instrument to apply heat to the smooth muscle surrounding the airway to try to decrease its spasticity. This has been a technology that's been around for several years and really hasn't quite gotten as much momentum as people were thinking initially. Since it's come out, there's been a number of new medical treatments for asthma that have helped control people who previously were having difficulty with managing their asthma. Often with people with very difficult to control asthma, we go back to making sure that they are using their medications appropriately, that they have appropriate inhaler technique, and also reduce triggers. Those have all been able to reduce the need for more radical things like bronchial thermoplasty. The last issue is many insurance companies will not cover it, and so it's less widely applied than some people might like.
Thank you. Dr. Harden, this is from Georgina in Duluth. What is the difference between alpha-1 antitrypsin deficiency and COPD? And she also wants to know, are there treatments for alpha-1 antitrypsin deficiency?
That's really a great question. So alpha-1 antitrypsin is a protein that we all have in our bodies. And the role or function of that protein in our body is to fight inflammation. Well, inflammation is what causes scarring in the lungs and and breakdown of the lung tissue, which can ultimately lead to COPD. The primary cause of COPD in the United States is smoking. But there's a small subset of the population who have a genetic predisposition to getting COPD because they're deficient in that protein, alpha-1 antitrypsin. It's not common, but it can lead to a very severe form of COPD at a young age, and that is why we would want to identify those individuals or know that it's in their family, because I don't think anybody should be smoking for lung health, but people who have alpha-1 antitrypsin deficiency are very prone to developing COPD and emphysema. Fortunately, there is a treatment for alpha-1 antitrypsin deficiency where simply we take the protein that was manufactured from another source, either in a laboratory or isolated from other individuals' blood plasma, and we can administer that protein to individuals who have alpha-1 antitrypsin deficiency. But usually, it's after they've developed more severe form of COPD that we initiate that therapy.
Thank you. Dr. Wall, this question is from Michelle from War Road. Michelle is wondering how marijuana affects your lungs.
Michelle, great question. It's tough to answer because we should first make a distinction between synthetic marijuana and sort of natural plant-based. Whenever you combust either of these, there are going to be a number of, when the heat of that combustion, a number of other byproducts that are inhaled into your airways. And they can lead to chronic inflammation and damage similar to cigarette smoking. And the particular chemicals are, with the synthetic marijuana, are much more harmful. Now, I don't want to say that there is no harm associated with the plant-based as well, but the second part of the question was?
Basically, she just wanted to know how marijuana affected the lungs. Yeah.
So, yeah, the products of combustion can be harmful. And I know Dr. Keenan had given a grand rounds on this too, and you may have something you wanted to add.
Yeah, more on I think you can deliver THC in a couple different ways. I think the main effect that marijuana would have on your lungs is just an irritant. And I think in the short term it would just make you cough a lot. In the long term, it will it's basically an unfiltered cigarette, so it would expose you to the same unpredictable combination of toxins that cigarettes do. Additionally, it's a risk factor for aspergillus infection, which is a fungal infection. Also, marijuana can be mixed with either knowingly or unknowingly with other chemicals that decreases predictability.
That's true. Move on to you, Dr. Harden, since that was a dual answer. Eugene from Chisholm says, I was diagnosed with sleep apnea over 10 years ago, and I've been using a CPAP ever since. Should I have my sleep apnea rechecked by a doctor?
Yeah, that's a good question. I think that individuals with sleep apnea, it definitely needs to be monitored. As people age, our bodies change, our lung function changes, people's weight might change. So how they adjust the settings on their CPAP machine, the amount of pressure that's provided to support their respiratory function and stuff like that can definitely change with time. So it's definitely something to talk with your physician about. When patients come into my office and they want to know about their function of their sleep apnea equipment or the CPAP, a lot of times they will have printouts from their machine that helps to monitor how they're breathing at night. So they can bring that to the company that manages their CPAP equipment, and they can adjust their equipment appropriately. But the short answer is yes, they should have it adjusted periodically.
Okay. Thank you. Don from Duluth either has or knows someone, apparently, who has continuous phlegm production. So he's wondering, what's the most likely cause and source of continuous phlegm production? Is it from the lungs, the bronchioles? What do you think, Dr. Wall?
This could be a chicken or egg question for Don. So certainly, especially this time of year, ubiquitous, we spend a lot more time indoors. There's a lot of pet dander. Indoor air quality really suffers in winter. And then come spring and summer, you have, your allergens in the air. So a sort of allergic rhinosinusitis, so basically a allergic sinusitis with a postnasal drip, could be a persistent phlegm problem because it then drains down the back of your throat and could potentially seem like it's coming from your airways. Or persons with persistent inflammation in their lungs, and the number one cause for that would be cigarette smoke. But of course, people with other, perhaps chronic infections, fungal, bacterial, could have really heavy amounts of phlegm or sputum production and be coughing too. So lots of times it's produced up in the sinuses and the airways and drains down and is kind of coughed up thinking it comes from the lungs, but it could also be coming from the actual airways, the bronchioles, and that's often caused, a bronchitis would be the sort of generic term we use for that, and the number one cause of that is cigarette smoking. But there are a couple associated infections that could cause that too.
So the phlegm can come from more than one location, above your lungs, in your lungs. Yep. Thank you. Dr. Keenan, Mary from Carlton is wondering, what is a pulmonary function test and what kind of information does it tell the doctor?
That's a good question. So there are a number of different pulmonary function tests. The one that people encounter most frequently, both in specialty clinic or in primary care clinics, is spirometry, and that's kind of a rough estimate of how efficiently air moves in and out of your lungs. That can help us screen and monitor for airway diseases, mainly asthma and COPD. Other types of lung function tests can give us more detail. Lung volumes we'll use when we're monitoring more restrictive lung diseases. We can estimate gas exchange, and we can also measure types of lung inflammation. But spirometry is probably what people see most frequently.
Thank you. We just have another minute or so left. Dr. Harden, Karen from Duluth, she says, I was just diagnosed with asthma and I was given a steroid inhaler. Will I be on it forever or until my asthma has cleared up?
Generally speaking, I know we're kind of running out of time here, but if somebody has asthma to the point that they're going to be prescribed a daily inhaled steroid, they're probably going to be on that for for forever.
Okay. Do we have time for one more? Okay. This last one is, what is the difference between asthma and COPD?
Reversibility.
Nailed it.
Right.
So by definition, like Dr. Keenan mentioned, air flows in, air flows out. So when you have asthma and COPD, air flows in but doesn't flow out well, and sometimes with the asthma, when it's severe enough, air doesn't flow in or out well enough, and so we give medications to reverse.
Thank you so much. I want to thank our panelists, Dr. Ryan Harden, Dr. Andrew Keenan, and Dr. Jason Wall, and our medical student phone volunteers, Claire Baumgartner, Michaela Lassard, and Jennifer Tamala. Please join Dr. Paula Tremulin next week for a program on elder care when her panelists will be Dr. Mark Boyce, Dr. Jeff Copeman, and Dr. Amy Greminger. Thank you for watching. Thank you for coming out on Valentine's Day tonight, gentlemen. Good night.